You're watching the Wellness Hour, news that makes you healthier. I'm Randy Alvarez. Today's topic, new treatment options for people that are in pain. With us, we have a board-certified interventional pain management specialist, Dr. Matthew Ranson. Dr. Ranson, welcome to the program.
Oh, thanks for having me, Randy. Pleasure to be here.
Now, big topic, right? We're going to also address the opioid epidemic. You said that about 95% or more of everybody on opioids could be taken off.
Absolutely.
And still have pain relief. So we'll get to that too. And we're going to talk about stem cells or this regenerative treatment near the end of the show. But first off, who's the typical patient you see in your center?
So we have a wide variety of patients. You know, obviously Arizona is kind of the mecca for retired older patients. So we have a lot of patients with regenerative or degenerative conditions such as spinal stenosis, degenerative disc disease, arthritis of the knees, shoulders, hips. You can imagine, and you get in your 80s, you have a lot of degenerative conditions. But we also have a lot of young patients because we're an outdoor playground.
Okay.
I mean, we have a lot of, people probably don't know this, we have a lot of hiking, mountain biking in the mountains that surround the valley. So I have a lot of patients that get either acute disc injuries from participating in one of these sports, or we have a lot of patients that ski. I'm a huge skier myself.
Okay.
So I see a lot of torn menisci and other soft tissue injuries. So it's really just a wide variety of patients from different age populations that we treat.
So you're treating like neck, shoulder, knees, back pain. Like what's the number one type of problem you see? Mostly back pain?
I would have to say the majority of patients have back problems.
Okay.
Yeah.
Now, you know, we're talking in the green room. Many of your patients go to you because they don't want a fusion surgery.
True.
And you didn't use the term refuse to fuse, but you don't like, I mean, you're not a big fan of fusion for most people.
I think fusion is overutilized in a lot of markets. Now, I work with some really great spine surgeons.
Okay.
And what's interesting is in the last few years, a lot of them have really moved away from doing fusions. Now, there's a select population, my mother being one of them, that had high-grade spinal stenosis and was suffering spinal cord damage, and she needed a fusion, right?
Okay.
I mean, there's no way we're going to get around that. No medication, no minimally invasive treatment would solve her problem. And she had some instability. But outside of that, if you're fusing for pain, you probably are doing the wrong thing for the patient. And we have so many other treatments now.
You say it's like a last resort.
It's a last resort in the absence of instability or high-grade compression of the spinal cord or nerves.
Okay. Now your specialty,
Right.
Interventional pain management.
I don't like that term.
You don't like that term?
I don't like pain management.
Tell me about that.
You know, well, I think, you know, I'm more recently trained, even though I finished about 12 years ago, but I think pain management has negative connotation. Why do I say that?
How so?
Well, I think pain management to the general public and even to my ears means medications. And guys, you know, people that trained when I did, we were kind of the new guard coming out, you know, about 10, 12 years ago, 15 years ago. And the big emphasis, even in the mid-2000s, was to stop prescribing medications. And that doesn't...
So that's what an interventional pain management physician, their goal is to get people off meds.
Absolutely, because medications are toxic. All of them have bad side effects.
But they work for many people.
Right, temporarily, but our goal is to get people off of medications. Why? Because they have side effects, very negative side effects. You can look at over-the-counter Advil. The research is overwhelming. You know, I used to take it when I was younger, before I knew the dangers of it that have come to light in the last few years. You know, NSAIDs, non-steroidal anti-inflammatory medications, Advil, Aleve, and there are other prescription doses of those medications. They're well known to cause heart attacks, stroke.
Okay.
They cause, you know, ulcers, kidney damage.
So there's things you could do to avoid those? Because
Absolutely.
those things work
I
too.
mean, they work temporarily, like I said.
All right.
But none of these things actually address the underlying cause of the pain, do they? You're putting a Band-Aid on it. In fact, NSAIDs, steroids, so Aleve, Advil, and steroids that we give like candy to patients, what do? They shut down inflammatory reactions, right? But what also they're doing is impeding your body's ability to heal itself. And sometimes that results in a permanent injury. So what my goal is, and guys trained like me and young women who were trained when I did and even now, our goal is to prevent using these medications, allow your body to heal itself.
Now we talked on the phone, and one of the most promising procedures that you really like is, I think it's called Kyphoplasty, is that right?
Correct, yeah.
So what type of problems is it good for, and how does it work? And I know you brought a video, so we'll take a look at that too.
I think it's one of the most underutilized procedures in my toolbox, in many interventionalist toolbox. You know, basically in a nutshell, Kyphoplasty treats compression fractures. And it's one of the most probably not talked about topics in medicine. Who does it affect? Mostly elderly osteoporotic patients, meaning they've got low bone density, right? And so the typical patient is in her 80s, and it's usually a female, although I treated 2 men last week with compression fractures who just missed fortune.
So compression fractures is very common?
Very common. It's a spine fracture.
Okay.
And it may result from a fall. It's not just your hip you can break. You've got a lot of vertebral bodies in your spine that are also subject, probably as high a frequency as hip fractures to falls. Sometimes, unfortunately, they just sit down wrong on a seat, or they cough and they get a spontaneous fracture.
So how is it typically treated, and what are you doing?
Well, unfortunately, the word's really not out about kyphoplasty among even physicians, much less people in the community. So typically they go to the emergency room or their primary care doctor and they put them in a brace sometimes. Or if they're really immobile because they're mobilized because of the fracture, which is often the case, they end up in a rehab hospital for a couple of weeks where they're given medications.
So they're just kind of learning to live with this pain.
Right.
Caused from a bone fracture in the spine.
In the spine. When it's so easily treated in a very small 20-minute procedure in my office.
So you brought a video
Yes.
of this kyphoplasty. Let's take a look at the video.
So what you can see is you make a small incision and you place a needle into the vertebral body. Then you create channels in the vertebral body. Sometimes I take a biopsy if I'm worried about prostate cancer or breast cancer or something like that.
So those are considered discs? Is what I'm looking at?
No, this is the vertebral body. It's in between the disc or
Okay.
shock absorbers. You can see the white structure. The cannula is actually going into the fractured vertebral body. I'm creating some channels, and you can see at the bottom the fracture line in the bone, which is what's causing all the pain. And by the way, these are often so painful it's almost paralyzing. You can see the cement is being delivered real time.
So you're kind of filling in the gaps where the cracks are.
Absolutely, fill in the fracture line. And this is where the pain relief occurs instantaneously. This cement hardens in 20 minutes, reaches full hardness in 20 minutes.
So you could do the procedure in 20 minutes.
Typically, yes.
You kind of inject it, fill in the bony areas that are the cracks.
Correct.
And you're saying that their pain goes away oftentimes.
Over 98% of the patients who come into my office, some of them come in stretchers, wheelchairs, and over 98% walk out of there with just some mild soreness from the small incision I make. And by the way, I must tell you, the incision in the animation is much bigger than the one that I actually make.
Is that right? So
Yeah,
the pain
absolutely.
goes away. So this bone pain goes away right away.
In 98% of the cases, it's almost completely gone instantaneously.
So in all of Arizona, how many thousands of patients could benefit from this simple procedure to get rid of their pain?
It would probably be at some point during the year, I would
Tens of
guess,
thousands?
Tens of thousands.
You've done more than 700 of these procedures.
Yes.
And you want to do more. you say.
Absolutely. Because it's the greatest thing I've ever seen as far as pain relief. It's instantaneous.
Really?
Oh, absolutely. There is nothing else that fixes the pathology, that fixes the pain generator like kyphoplasty.
Now, logically, this makes sense, and I'm not an expert on this topic, but why isn't everybody doing it this way? What's your take?
I'm not sure. I mean, there's been...
You must have a take. Is it because of the training? They just don't have the training?
I think that's a huge part of it. I mean, there are risks associated with this. You don't want somebody performing this procedure that does 5 a year. There are huge risks associated with this and untrained hands. I mean, I've done so many. I won't say that I can't ever have a complication, but I never have. I mean, the cement can leak out. You can hit some neurological structures. I use a very safe system. It's pretty high tech. It's radio frequency activated. I've got a little remote control. I can turn off the delivery. And I'm doing this under, like I mentioned earlier, I'm doing it under 2 x-ray machines. And to my knowledge, I'm the only suite in the state that has 2 x-ray machines to do this procedure.
Now, for these people that aren't doing kyphoplasty, they've been told you have a fracture, they're taking their pain meds.
Right.
What happens when they do nothing? Like, what's their outcome?
Well, obviously, as I mentioned, I've treated hundreds of these patients, so I have a lot of experience with them. And I can tell you that there are really 2 sets of patients, right? So some will heal on their own within 3 to 4 months, but you can imagine during that 3 to 4 months, you're kind of incapacitated. You're not moving around, and your muscle mass in an elderly patient disappears very quickly in a week or 2 from immobility, all right? Which is a tough thing to come back from when you're 80 years old or 90. And a lot of the patients I treat are in their mid-90s, believe it or not. I treat a lot of those patients. The other thing that can happen, which is really dangerous and not talked about enough, is that fracture can continue to collapse. Because if you've got really low bone density, it will continue in many cases to collapse.
Pain.
Not just more pain, but something that's even worse, retropulsion. Many of these fractures are over the spinal cord, before it ends down the lower
So what's
lumbar spine.
retropulsion?
So that is where the bone fragments push against the spinal cord. Now you have an issue. If that fracture continues and is not stabilized, it can push back on the spinal cord. As you can imagine, that's not a good thing to happen.
Okay.
So now you're looking at a big operation to decompress the spinal cord, which at 80 years old may not be survivable.
Now, is this considered experimental treatment? I mean, does Medicare or Medicaid cover any of this?
Absolutely. Who do you think most of my patients are?
So it's covered by insurance?
Absolutely.
So it's just the challenge, I guess, you have is educating the public that...
And other physicians. You'd be surprised how many physicians don't know about this or know much about it.
So you spend a lot of time with primary care physicians, kind of letting them know the newer things?
Absolutely, and emergency room doctors who see these as well.
So what if somebody's been diagnosed like 4 months ago, 6 months ago with this? Is it too late for the kyphoplasty?
Unfortunately,
or do you want to catch it early?
You want to catch it early, and you want to catch it because I've seen fractures where I've gotten an MRI and done the kyphoplasty 3 days later. I'm very aggressive with these because I know what can happen, and I get them under X-ray, and what was a 10% loss of height is now 50%, literally in 3 days.
Okay.
With retropulsion.
So they're back to action, back playing at tennis possibly or golfing or whatever.
I'll tell you. I mean, I've got hundreds of stories, but one that sticks out of my mind, and I love this woman. She was 97 years old, and she and her girlfriend rolled their golf cart. It's Arizona, right? Everybody golfs. And she spilled her martini and crushed her cigarette. And unfortunately, she fractured her vertebral body up in high interthoracic spine. So they were wild, and her girlfriend was like 92. All right, so she loved to golf and ride her Harley. So she comes to me and she's incapacitated. And I fixed her fracture, and she was back golfing the next week.
Is that right?
Absolutely.
Out of pain.
Out of pain.
Does some patients go, I can't believe it?
They do. I can't tell you how many women, mostly because most of these patients are women, just because of the osteoporosis is more prominent in women, just get up and walk out of my office. I usually get an old lady kiss and a hug on the way out. I mean, it's that spectacular. So that's why I love this procedure.
So this is what an interventional pain management physician does.
Pain medicine.
Pain medicine.
Yes.
Does. Because you don't want to just manage the pain, your goal is to get rid of it.
Right, absolutely.
And without meds.
Absolutely. That's our goal.
Now at the top of the show, I said that you said that maybe 95% of all people on opioids could be taken off and still have pain relief.
Absolutely.
So tell me about that. And you say spinal cord stimulation is one of those things.
Yes, it's one of our most often used modalities.
What is it?
Well, so let's talk about who we do these procedures on. So in a nutshell, spinal cord stimulation is a mechanical means. We use electrodes placed in the spine to disrupt the pain impulses before they get to the brain and says, hey, my leg hurts or my back hurts.
So your brain doesn't get the signal that you're in pain?
That's
It confuses the...
It's an oversimplification, but what it does is the type of frequencies that we're using to disrupt the pain impulses are the type that are involved in neuropathic pain only. So for instance, if you step on a nail, your brain still gets the message, hey, I just stepped on a nail. Or if you put your foot on a hot coal, it says pull it away. That's not disrupted. That's a different type of pain impulse. What is disrupted is that nagging chronic pain from your back or from a leg injury after, say, a knee replacement. That's a typical patient that we see. So we use these very special electrodes to disrupt that pain impulse so you no longer perceive it as pain.
And it's called spinal cord stimulation.
Yes, that's one modality, the most often used modality.
And how long does that take for you to do in office?
So I do.
What's the downtime?
So you try it before you buy it, just like you take a test drive in a car. So the typical patient that we put this in will be, say, someone who unfortunately has already had a back fusion. And in over 50% of the cases, it doesn't take care of the pain. So we do a temporary trial. I just place a couple of these little electrodes through an epidural needle. It's just like
while they're in your office?
While they're in their office in a procedure suite. So I have procedure suites. It's done sterilely, just like a surgical procedure, but it's not surgery. It's like a fancy labor epidural. So you go home and you have a little battery pack and a bandage, and it's all external except for the two leads that are these very small leads that are in your spine. And you come back in 4 or 5 days, and then we assess whether it really provided significant relief. And it's always black or white. Either it was magnificent and it restored function, and you're able to go and do a lot of things you couldn't do before, or you failed it. And I will tell you that in my hands, less than 10% of people fail this technology.
So in this little trial, so you're actually, before you actually implant it in their body,
correct,
this stimulator,
yes,
that confuses the signal, I'm calling it confuses the signal.
That's a great way to put it.
Okay, to the brain so you don't feel the pain. So they try it. Do people ever on the spot say, they're walking out going, I don't even feel pain right now?
Absolutely. Depends on the type of stimulation you're using. A more modern stimulation, we're using one that I use extensively, is called burst, which is paresthesia free, meaning that our old stimulators, which we started doing them in 1967, believe it or not, were these big devices. And what they did was they made you feel tingling instead of pain. We've moved away from that. Okay, that's called tonic stimulation. Now we have high frequency and burst are two big examples where you just don't feel anything. The pain's gone.
Do you do a lot of these? I mean, is this a rare procedure or a common procedure?
It's
like
common.
every week you're doing it?
Yes, typically. I mean, I do typically over 100 of these a year. And it's a small surgical procedure to put them in. The analogy I use is it's a pacemaker for the spine. It's the same size as a cardiac pacemaker. The battery technology that drives this comes from pacemakers.
And people that were on opioid medications, you've had people completely off?
Absolutely.
After this procedure?
Absolutely. Yeah.
Without the side effects?
Without the side effects. There are no side effects. So, there's always a small risk of a post-operative complication from it, but it's very small. And it's a lot smaller. It's probably 1/15 as much as having, say, a back fusion.
With opioids for a second, I don't want to sidetrack here, but how do opioids even work? Like, what's the mechanism of why is it stopping pain?
Well, I don't want to bore you with technical details and receptors and all that stuff,
Okay.
which it bores me, to be frank with you.
Okay.
So oversimplification, what opioids do is they tell your brain to not worry about the pain. You still feel it. You know it's there. It's just kind of in the background. You don't care about it.
Is that right?
Here's the cost. There's no free lunch in life, as my father loves to say.
Okay.
Right? So the cost is, you don't care about the pain, but guess what you don't care about? You don't care about going to do your favorite activity. You don't care about the relationships with your family at home. Taking that hike or playing with your dog, that's no longer enjoyable. It numbs everything, not just the pain.
So that's the issue. So with a spinal cord stimulator, with the right candidate,
Correct.
you could accomplish the same thing but without meds.
Absolutely.
So spinal cord stimulation, how do they even find out about this? Because I mean, it sounds good, right? I'm not trying to side with you, but logically it makes sense. Why would I want a pill when I could do something like a spinal cord stimulation?
Mm-hmm. So a lot of the patients that come to me are sent by spine surgeons,
Okay.
and by primary care physicians that know me and have referred patients to me for years. And so now I go out actually and talk to these physicians, and I do lunches in their office, and I educate them on what spinal cord stimulation is, and among other things that I do. But that's how they find out about it. So one of the things to really, I think, impress upon people is that spinal cord stimulation, in many cases, changes your life. How does it do that? I'd say the greatest side effect of spinal cord stimulation is that it gets you up, moving around, and going back to your normal activities. Let me give you one of my favorite examples. And I've done probably close to 1,000 of these procedures in my 12, 15 years of doing them. I had a patient that came in and he'd had spine surgery, and they dinged a nerve, so to speak. So the patient comes to me, and the first time I see him, he's got this big brace on his lower extremity because it's paralyzed, partially paralyzed, and he's in excruciating pain, and he's using a cane, and he sits down, and he's been managed on high doses of opioids, morphine, and he's just miserable. This guy owned a company prior to this injury, and for years he's been managed with toxic medications, and nobody ever talked to him about spinal cord stimulation.
How do you even know if it's going to work? I mean, you do some sort of imaging and you go, hey, this person might be a great candidate.
You remember earlier I talked to you about doing a trial. You try it before you buy it. You take it for a test drive. So I know that...
So this guy who's in bad shape.
Right, he has a neuropathic injury.
You do a little trial on him.
I placed a couple of little electrodes through needles percutaneously, and he comes in 5 days later and he's changed. His brace is gone. And he's still using a cane because he has some weakness there, but he's taken the brace off. For the first time in years, he's walking without a brace. And he hugs me and he says,
That's nice.
I've got to have this. And so I implanted him, and then I watched him. Within 30 days, the color changes in his foot that resulted from the nerve injury. Sometimes you get discoloration. The mobility in his foot with physical therapy. This guy came back around 30 or 35 days for a post-op visit, and I'd already put him in physical therapy. He didn't have a cane. It was imperceptible to watch, his gait abnormality was imperceptible at this point. He was getting ready to start biking again. He was going to go back to work, and guess what happened to his pain medications? Against my advice, he discontinued them without weaning himself off of them.
So you have hundreds of these stories. I mean, this guy is not unusual.
No.
I mean, you see this all the time with this spinal cord. Is that what the patients should call? Hey, tell me more about spinal cord stimulation?
Yes, that covers.
Is that what they call it?
That's what they call it. It's evolved. So now we have something called DRG, dorsal root ganglion stimulation, which is very targeted stimulation, which doesn't technically over the spinal cord. It goes over the engine nerve root. But yes, I mean, neuromodulation is what we as physicians refer to it as.
What about things like pain going down the back of the leg, like a sciatica?
Absolutely.
Is it any good for that?
It's over 90% effective, depending on the type of stimulation, yes.
Because I know people with sciatica, they'll do anything to get rid of it.
Right.
And they're living on Advil and everything else.
Yeah, all those toxic medications we talked about.
So again, you do the little trial where they take it home for a couple of days.
Correct.
5 days.
5 days typically.
And you'll know if it works or not.
Absolutely.
And then you implant it. Now, Medicare, Medicaid, insurances cover this?
Blue Cross, Aetna, almost everyone. It's FDA. It's been FDA approved for decades.
Okay.
It's a well-known, well-researched device.
Fusion. I just have to talk about fusion. Right. We have to get, because I want to talk about stem cells in just a moment. But fusion surgeries, millions are being done, I guess, across the country.
Yes.
Okay. And, you know, it has its, I guess, complications and drawbacks and limitations, et cetera. But I think you told me, and I'm pointing to my green room, that most of these fusions could have been avoided with some of these other interventional procedures.
Unfortunately, that's the case.
Is that right?
Yes. In many cases, like I said, in the absence of high-grade compression or instability of the spine, I mean, that's a fusion typically. But in the absence of those two things, fusing for pain rarely works. If you look at the big studies they've done with tens of thousands of patients, the 2-year outcome data is really poor. It's less than 50%. And they typically come back, they come to me at some point and they still have the same problem they had to begin with, and often it's worse.
I told you I have a buddy, super healthy guy. We were playing tennis 2 months.
Right.
He has some like ongoing back problem. He gets a fusion surgery. He's out for 2 months. He was even using a walker. And I asked him after talking to you, I said, did you ever even speak to interventional pain management? Never heard of the term?
Right.
And the answer was no.
And that's sad that that's often the case.
So that's common.
Yeah, and apparently he didn't really have any other types of conservative therapy, just went straight to fusion.
That, according to him, that's what he did. He didn't even try chiropractic or any of those things.
Right, I mean, that's where you start.
Is this a big reimbursed thing that means, spinal fusion, insurance companies pay a lot for?
Yes, it's a lot more expensive than any things that you and I've talked about that I do.
Okay, good. Yeah,
significantly.
Now, the hot topic, you refer to it as regenerative medicine.
Yes.
I called it stem cells. You corrected me.
Right.
So let's talk about that.
Well, I think the term stem cell is very deceptive. I think it's a marketing tool.
Okay.
It really does the whole field of regenerative medicine injustice. And I don't know that I told you this, but I was in a graduate PhD program in molecular biology before I went to medical school in the 90s. It was so long ago that we hadn't sequenced the human genome. So preface it with that. But I have a particular passion for regenerative medicine because I see that this is the wave of the future. If it's done correctly, you can reduce pain and restore function. And what do I mean by that? A typical patient that comes to me, or there's two sets. You've got patients with joint injuries or degenerative arthritis.
Like knees, shoulders,
hips.
Okay.
And those patients come in and they're a skier, or they were running and they tore a meniscus, or they've just worn their joint out. And I can treat them with regenerative products and get them back.
These are like injecting growth factors.
Growth factors, that's the key. Into the damaged structure, yes.
Which are often referred to as stem cells.
Again, I think that's very deceptive.
Are there some dead stem cells in there? I mean, why are they even calling it stem cells?
So it depends on what you're using. You know, back when I initially started doing this in the dark ages of regenerative therapy.
Okay.
10
years ago.
Yeah, 10 years ago, but really it's advanced so fast.
Okay.
And what we're using now, we didn't have back then. But I used to get the typical patient was an elderly patient, and I would suck out their fat using tumescent liposuction.
Okay.
So the women loved it, all right, because I'm doing liposuction on them, using my old plastic surgery skills.
Okay.
And then we would spin this down in this fancy centrifuge, and I had a lab tech in the hood and all this other stuff. And then I'd put this into the damaged structure. Now we have...
Did they get better?
Sometimes.
Okay.
But what am I using? I'm using the growth factors of an old person, which are old.
Okay.
Notice old. All right, so where we are now. So now we have these amniotic products. Now what is amniotic?
From babies?
Not from babies. That would be immoral and unethical. And
okay.
We never touch babies. So we have the typical C-section patient that's healthy, right? So they donate their fluid and other parts of the birth, placenta, for instance, to these tissue banks. And then they've been tested for all the other Hep C and HIV and all that stuff. So we know they're healthy, and they voluntarily gave the afterbirth products to this tissue bank. So we take that, and in my case, what I use is something where we take the placental cells and we grow those in a lab, okay? So no baby's been around that.
All right,
and it produces sterile amniotic fluid. And this fluid does contain some stem cells, but more importantly, it contains growth factors. We then hit this with radiation to kill the stem cells. Why? Because we have absolutely no evidence that stem cells, in fact, do anything, that they actually would incorporate in any structure we put them in. It's the growth factors that we know.
So you inject these growth factors into wherever the pain's coming from?
Yes, into the pain
Could
generator.
be a disc?
Could be a disc.
Could be a bony part of the body?
We haven't used them a lot. We use it to restore the soft tissue in the bony joint.
So the results are good on certain people?
Yeah, on certain patients, it's not a panacea for everyone, but the patients that respond to this get just phenomenal results. I have one patient, two patients that stand out that are older. One was a Vietnam vet, Marine Recon, and he came to me with pain in his cervical, thoracic, and lumbar spines. This guy had done tons of jumps and had several combat-related injuries, and he's now a Western stuntman. Okay, and he makes movies and other things, and he's in his late 70s. And I told him, I said, you need surgery. This won't help you. And he had more money and than he he did time, right? And this guy did not want to have surgery. And he actually talked me into doing this. This is why he stands out, because I didn't want to do it. I wasn't going to hurt him, but I just didn't think it would help him. I thought he was wasting his money. So he started his lumbar spine.
Because insurance doesn't cover some of this.
Insurance doesn't cover any of this.
The regenerative treatments.
It's considered experimental.
Giving growth factors in the
growth factors, right. So this guy didn't want steroid injections, which are toxic. He just wanted to get better. So I said, okay, well, we'll start in your lumbar spine. If it doesn't work, I'm not going to treat the rest of you. And we're going to start small. He said, fine. So I treated his lumbar spine. 3 months later, which is about when we start to see significant decrease in pain and restoration of function, he comes in, he's like, I want you to treat my thoracic spine. I said, okay. So I treated his thoracic spine. And then 3 months after that, he came back, and his thoracic and lumbar spines were nearly asymptomatic. He said, I want you to treat my neck, which was the worst of it. And I told him again, this isn't going to help you, you need surgery. Okay, that was 2 years ago.
Were you shooting these growth factors into the discs?
In some cases, depending on the pathology, discs, facet joints, adjacent structures, whatever is damaged, and I have MRI imaging and I'm very selective and targeted where I place these growth factors.
We're out of time. So final message, somebody watching this, they think they've tried everything, but they've never seen an interventional pain physician.
Right.
What do you say to them? And they've heard about this. They're going, I haven't heard anything about this spinal cord stimulation. I haven't heard about some of these injection therapies using growth factors and things like that. What do you say to them?
I say get online, talk to your primary care physician. I mean, they know a lot, right? They're the gatekeepers. Talk to them, see if they have any recommendations, but do your own research. Make sure that they're fellowship trained, because there are many physicians out there who are not fellowship trained, and they're board certified. And then do your own research about what type of therapies they offer, because not all of us offer the same therapies.
But if you go to a board certified interventional pain specialist, you pretty much know that their philosophy is no medications.
Not true.
If at all possible?
That's not true. No, unfortunately, it's not all of us. It's only some of us that are kind of pushing the edge, and that were more recently trained than others.
So you think, because there's lots of stuff in the news about the opioid epidemic.
I've been saying that for 20 years.
Right. In fact, you said your kind of claim to fame in the early 2000s, 2003, 2004, you were against opioids back then.
Even when I was in surgery, as a surgery resident, I thought they were toxic back then.
But you didn't have an alternative therapy back then like you do today.
No, I didn't.
And now you do.
And now I do.
So, all right, well, good. So if somebody's watching this, they can call. Do they get to see you or somebody on the team? Because you have a pretty...
I see most new patients. I see all the regenerative medicine consults, and then I have physician extenders that work in my office, and sometimes they see them if I'm in the operating room or something like that.
Okay, good. I want to thank you for coming on the show. Good stuff.
Thanks for having me.
You've been watching the Wellness Hour, news that makes you healthier. I'm Randy Alvarez. For now, I wish you good health.
Thanks for watching the Wellness Hour, the leader in medical news with your host, Randy Alvarez, the authority on health issues.